When we think of female biology, estrogen usually takes center stage. But in her 20s and 30s, a woman's body actually produces 3 times more testosterone than estrogen. By age 40, those testosterone levels begin to fall. That missing hormone is a primary culprit behind the sudden drop in energy, mental fog, and complete loss of sex drive that many women experience during perimenopause. Take a look at this data from the Closer survey. It shows that 74% of women going through this transition experience physical discomfort that actively causes them to avoid intimacy. This creates a silent crisis behind closed doors. Spouses often misinterpret this physical withdrawal as a loss of affection. Meanwhile, the woman is left feeling alienated and betrayed by her own changing body. Intimacy avoidance during this transition is a biological medical issue, effectively ending the misconception that it is a personal or marital failure. Introducing testosterone to boost libido will fail if the physical act of intimacy remains excruciating. As estrogen levels collapse, vaginal tissues undergo profound physical changes, a condition diagnosed as genitourinary syndrome of menopause. The tissue becomes extremely thin and loses its natural elasticity. Even the local environment shifts from a protective acidic state to an alkaline pH, making the area prone to tearing and infection. The mandatory first step of the protocol is healing that tissue. Doctors prescribe localized vaginal estrogen or specialized moisturizers. These target the affected area directly to restore blood flow and elasticity without circulating high levels of estrogen throughout the entire body. Resolving the pain of genitourinary syndrome removes the physical barrier to intimacy. However, making sex painless does not automatically restart the engine of sexual desire. Once the pain is treated, a persistent lack of libido can often be traced to a specific medical condition, hypoactive sexual desire disorder. This chart maps out a woman's hormone timeline from age 20 to 50. We can see the androgen gap forming here, with a steep 25 to 50% drop in circulating testosterone intersecting right here at age 40. As that testosterone drops, it drags down the brain's sexual response system. The brain produces less dopamine for motivation, less serotonin for emotional connection, and less norepinephrine for physical arousal. Physicians diagnose this deficiency by measuring bioavailable testosterone using the free androgen index. A symptomatic woman testing in the lowest quartile, specifically under 1%, has a severe chemical deficiency. When a woman reports that she no longer feels like herself, she is describing a measurable biological lack of neurotransmitters. It requires targeted medical supplementation to fix. Despite hypoactive sexual desire disorder being a recognized medical condition, there is a glaring contradiction in modern healthcare. There is no FDA-approved testosterone product for women. To treat their patients, menopause-trained professionals rely on an off-label workaround. They prescribe testosterone products designed for men, but instruct women to use highly fractionated doses. Guidelines require precision, like 1/8 of a male testosterone sachet daily, or a single pump of testosterone on alternate days. To prevent side effects, doctors require strict monitoring, checking testosterone levels before and during treatment to keep doses within the normal female range. Navigating this fractional dosing safely requires specialized training. A general practitioner without dedicated expertise in menopause is rarely equipped to manage this nuanced therapy. This brings us to the power trio of hormone optimization. Estrogen maintains tissue and bone health. Progesterone regulates sleep and mental clarity. Testosterone provides libido and physical drive. Balancing these 3 hormones actively optimizes the aging process, safeguarding muscle mass, cognitive function, and long-term relationship health. The menopausal transition is a solvable biological equation. By identifying and treating the root chemistry, partners can stop fighting each other and instead team up to fight the hormones. Are you or your partner feeling this, this disconnect that you just can't quite put your finger on? A tension that feels like it just appeared out of thin air? Well, what if I told you that the secret to what might be straining your relationship isn't about how you communicate, or fighting over money, or even a lack of love, but it's about a hidden hormonal shift, one so powerful it's almost never talked about, even by doctors. In this deep dive, we're going to pull back the curtain on the one hormone that could change everything about how you see your relationship. So stick around, because this is the conversation you really need to have. This quote from a real patient, it just cuts right to the absolute heart of the issue, doesn't it? It's this quiet crisis that's happening in bedrooms everywhere. That vibrant intimacy that might have been a cornerstone of your relationship suddenly becomes a source of pain and anxiety and just stress. And if this feels even a little bit familiar, you need to hear this. You are so not alone. This is not a personal failure, and it's definitely not a sign that your marriage is doomed. It's a biological reality that we all just need to understand. Okay, look at this number. 74%, that private struggle we were just talking about, it's shared by nearly 3/4 of women in this stage of life. This isn't some small minority. This number represents something called Genitourinary syndrome of menopause, or GSM. Now that's the clinical term for a whole collection of symptoms. We're talking vaginal dryness, urinary issues, and painful intimacy that can totally torpedo a woman's quality of life, and of course, her relationship. And the reason it's a silent epidemic? Well, it's buried under all these layers of taboo about female aging and sexuality, and honestly, a huge gap in medical training where these issues are just dismissed or totally overlooked. This isn't a niche problem. It's a silent epidemic happening right under our noses. So let's just call this what it is: the relationship red zone. This is that critical time when hormonal changes create this perfect storm of physical discomfort and emotional volatility, and it puts this immense strain on even the strongest partnerships. We're about to break down exactly what that storm looks like. So what does this red zone actually feel like? Well, it starts with things that are so easily misunderstood. That feeling of being constantly irritable. Some people even call it perimenopause rage. That's not you just being difficult. It's hormonal shift that can make a totally neutral comment feel like a deep personal attack. And that right there is what leads to partners feeling like they're constantly walking on eggshells. Then the storm gets worse with the physical side. Intimacy becomes painful, a medical condition called dyspareunia. And this pain, combined with a natural drop in desire, leads to avoiding physical connection completely. And what's the foundation for all this chaos? Chronic sleep disruption from things like night sweats and insomnia. It's like the ultimate accelerant, just pouring fuel on the fire, totally destroying your frustration tolerance and making clear, rational conversations feel, well, almost impossible. This slide right here, it really gets to the core of the whole disconnect. Just look at these numbers. While 64% of women are dealing with a loss of libido and 58% are actively avoiding intimacy because it physically hurts, more than half of their partners are completely in the dark about the real reason why. All they know is that something has changed. They feel rejected, they might blame themselves, or they might blame their partner, not even realizing this is biology. It's not a verdict on their relationship. This right here is the intimacy gap. If this is resonating with you at all, seriously, let us know by liking this explainer, because just recognizing this gap is the very first step. Now let's decode exactly why this is all happening on a biological level. To really understand the solution, we have to understand the source. So I want you to think of your hormones not as just random chemicals, but as this finely tuned orchestra. And during the menopause transition, the three main musicians, your body's power trio, start playing way off key. Let's meet the players. So first up is progesterone, and we'll call it the orchestra's conductor. Think of it as your body's natural calming agent. It actually works on the GABA receptors in your brain, the same ones that anti-anxiety meds target, to help you feel relaxed and sleep well. But during perimenopause, which can start as early as your late 30s, its levels don't just gently go down. No, they fluctuate wildly, like a conductor having a seizure. And when progesterone suddenly tanks, you get this state of estrogen dominance, which sounds great, but it's not. It's what leads to that feeling of simmering anxiety, being more sensitive to pain, and that quiet rage where you feel like you could just snap at any moment. This is the very first musician to go off key, and it's a signal that the entire orchestra is about to fall out of sync. Next up, let's talk about estrogen. If progesterone is the conductor, estrogen is the entire string section. It provides all the lush foundational support for tissue health, especially down in the pelvic region. Estrogen is what keeps your vaginal and bladder tissues plump and hydrated and elastic because it maintains collagen and blood flow. As its levels decline in menopause, those tissues get thinner, drier, and way more fragile. And that is the direct cause of GSM. The dryness, the pain, and even a higher risk of UTIs, because estrogen helps keep the vagina's protective acidic environment in check. Okay, so we've covered the two hormones everybody knows about, but the third member of this power trio is the one you've probably been told is a male hormone. The truth about its critical role in the female body is the missing piece of the puzzle for millions of women. And it might just be the most important part of this whole story. And here it is. The missing piece. Testosterone. And yes, it is absolutely a female hormone, and a really, really important one at that. In the female body, testosterone isn't just about libido, though it's for sure essential for that. It's the hormone of drive, of motivation, of mental clarity. It supports lean muscle mass, bone strength, a stable mood, and your overall energy. You know that feeling of having a zest for life? Yeah, in large part, that's your testosterone talking. So if it's so important, why isn't it part of every single conversation about menopause? Well, that brings us to the testosterone controversy. This is where medicine, history, and a major lack of research on women's health all collide. And it creates this gray area that leaves so many women completely without answers. Before we even get into the history, I have to drop this bombshell fact on you. In her reproductive years, a healthy woman's body produces 3 times more testosterone than estrogen. Just let that sink in for a second. The hormone that our society connects almost exclusively with men is actually the most abundant and active steroid hormone in the female body for most of her life. It is not an optional extra. It is a biological cornerstone. And what's so sneaky about this loss is how it happens. See, unlike estrogen, which kinda drops off a cliff at menopause, the decline of testosterone is a long, slow burn. As you can see from this timeline, it starts way back in your 20s. By the time you hit 40, you may have already lost half of your peak levels. So when perineum menopause shows up and the other hormones start their chaotic dance, you're already running on a major deficit of the very hormone that's responsible for your drive, your energy, and your desire. You're basically entering the storm with your sails already torn. So this begs the obvious question, right? If it's so vital, why isn't there an FDA-approved version for women? Well, the story goes back to 2004. A testosterone patch designed just for women was brought to the FDA, but the timing was just awful. It was right after that now infamous Women's Health Initiative study, which had created this widespread and largely misplaced fear around all hormone therapy. So citing a lack of long-term safety data, the FDA denied the application. A lot of experts felt this was way too conservative, but it basically froze all mainstream development, and it pushed testosterone for women into this off-label medical gray zone, where it's been ever since. I am so curious, does this history surprise you? Let me know down in the comments. And if you're finding this explainer valuable, subscribing is seriously the best way to support our work as we dive in and separate the real science from all the hype. So let's just cut through all the noise. What does the actual evidence-based science say about using testosterone for women? It's not some magic bullet for everything, but for one very specific condition, the evidence is crystal clear. According to global consensus guidelines, and this is the official evidence-based stance, there's only one validated reason to prescribe testosterone to women, and it's for a condition called hypoactive sexual desire disorder, or HSDD. Now, this isn't just, being in a low mood or feeling tired after a long week. HSDD is a clinical diagnosis. It's defined as a persistent lack of sexual thoughts or desire that causes the woman marked personal distress. And here's the really crucial part. It can only be diagnosed after all the other potential causes, like relationship problems or side effects from other medications or physical pain from untreated GSM, have been totally ruled out. It's like a very specific key for a very specific lock. And this distinction is so important. The science robustly supports testosterone for HSDD, full stop. But what about all the other incredible benefits that women often report? Improved energy, better mood, easier weight management, getting their cognitive edge back. Well, as of right now, the data from the big, large-scale controlled studies hasn't consistently validated these other outcomes. Now, that doesn't mean they aren't real for the women who experience them, but from a purely scientific, evidence-based perspective, they're considered anecdotal. The only proven validated reason is for restoring sexual desire. And this brings us to what is maybe the single most important factor for safety: dosing. The goal of testosterone therapy in women is to restore levels to the normal, healthy, physiological range of a young woman, not to go past it. This is usually done with transdermal creams or gels, where the dose can be carefully controlled and monitored with blood tests. The danger comes from what we call supraphysiological doses, levels that are higher than what's normal for a female body. These higher levels are often associated with less predictable methods like pellets or oral testosterone, and they carry a much higher risk of side effects. And these are the potential side effects that everyone worries about. The truth is, with proper physiological dosing, side effects are actually pretty uncommon. Some women might see a little bit of mild acne or oilier skin, which is usually reversible just by adjusting the dose, but the more serious, masculinizing side effects, unwanted hair growth, male pattern hair loss, and especially the irreversible changes like a deepening voice, are almost exclusively linked to those high supraphysiological doses. So the takeaway here is simple. The method and the dose are everything. If this scientific breakdown has been helpful for you, please share this explainer with someone in your life who really needs this clarity. And make sure you're subscribed with notifications on, because you are not going to want to miss this final section where we turn all this knowledge into real action. Okay, so we've covered the problem and the science. Now let's pivot to the solution. How do you take all this information and actually use it to reconnect with your partner and reclaim your health and your vitality? It is not about finding a single magic pill. Leading experts, like the British Menopause Society, they emphasize what they call a biopsychosocial approach. Now, it's a fancy term, but it's for a really simple idea. You have to look at the whole picture. Yes, the biology of the hormones is a massive piece of the puzzle, but you also have to address the psychological factors, like stress and body image, and the social factors, like the specific dynamics in your relationship. Testosterone can't magically fix a communication breakdown that's been going on for years, but fixing the underlying biology can make it a whole lot easier to start having those crucial conversations again. So here it is, your actionable path forward. Let's break it down. Step 1. Start the conversation. Share this information with your partner. Explain that this is a medical issue, a biological shift. It is not about them. Step 2. Find the right expert. Look for a doctor or provider who is a certified menopause practitioner or has specific training in this area. Not all doctors are up to date on the latest guidelines. Step 3. Get a full assessment. This should include checking all the relevant hormone levels and ruling out any other medical or psychological causes for your symptoms. And finally, step 4, create a team plan. This is something you, your partner, and your doctor should all be working on together. It might involve hormones for you, but it also involves prioritizing sleep, managing stress, and open communication for both of you. And here's a crucial final point on that you absolutely cannot forget. You can't just treat testosterone in a vacuum. Experts stress the synergy between hormones. For testosterone to actually work and improve desire, the tissues themselves have to be healthy enough for intimacy to be pleasurable, not painful. That means you have to first address the GSM. You have to make sure those tissues are adequately estrogenized, often with local topical vaginal estrogen, to fix the dryness and the thinning. It's a foundational step. You have to rebuild a house before you can even think about turning the lights back on. This brings us to a final and pretty provocative question that's often debated. If you don't use it, you'll lose it. Now, while the hormonal decline is inevitable, there is some science that suggests that maintaining sexual activity can help with blood flow and tissue health. But it becomes this really complicated, almost cruel question when the activity itself has become painful or undesirable. It's the ultimate chicken and egg dilemma that so many couples find themselves in. So what are your thoughts on this? Is there truth to that old saying, or does it just add more pressure to an already difficult situation? Leave your thoughts and experiences in the comments below. Let's keep this important conversation going. Thank you so much for joining us for this deep dive. If this was valuable to you, please subscribe and turn on those notifications so you don't miss our next explainer.